Hi, I'm Dr Raelia Lew from Melbourne IVF. I'm going to be talking to you later about egg freezing in a webinar, and I'm on my way to do some egg collections now. I look forward to speaking to you later.
So egg freezing is one element of fertility preservation. Of course, when we broadly talk about fertility preservation, we also talk about medical fertility preservation. And I'll go into that in a little bit more detail, but the current terminology we use is elective or planned egg freezing, when a woman decides to freeze her eggs as part of her proactive reproductive plan in the absence of serious disease or gynecological problems. Of course, egg freezing is quite controversial, probably because it's new. I mean, I think the technology is something that is really, truly amazing. But it is very new. I can tell you during my training as a reproductive endocrinologist, egg freezing went from being something quite experimental to something that really has been embraced as part of mainstream assisted reproductive treatment pathways. And there are reasons for that. Really, we've become monumentally better at egg freezing in the last decade. It's a challenging thing to do, and a huge achievement of assisted reproductive technology to freeze a human egg in a way that it can be warmed and successfully used to make a baby. It's something that's become increasingly relevant as our behaviours change, and certainly during the course of the last couple of generations, there's been kind of major shifts in when most people have their babies. In our grandparents' generation, for example, the average woman would have her first child in her very early 20s, whereas in our generation, we're really shifting into the beyond 30 bracket. And when we say the average age of a first-time mother is now over 30, what that means is actually 50% of first-time mothers are aged 31 and above. So we have more women attempting to conceive at a time where our natural fertility does decline. And in context of that, egg freezing has the potential to really improve the number of women that are able to have babies with our own eggs, and to improve the number of children we're able to have if we are starting our family later in life. Unfortunately, age has a significant effect on fertility. I always say it's not a cliff. You don't turn 35 and suddenly a light switch turns off and you've gone from fertile to infertile. It's really not like that. But what does happen is from really our early 20s to about 30, our fertility is fairly constant. And then there's a gradual decline between 30 and 35, and then a more rapid decline from 35 to 40. And the statistic that many women may not be aware of is that 50% of women over 40 who do successfully conceive do so with a donor egg, or an egg from somebody else rather than an egg of their own. And that's because eggs are really unique. Unlike men, we create all our eggs at the beginning of our lives when we are ourselves in utero, probably at a time point that your mother has not told anybody about her pregnancy. You've made all the eggs you're ever going to make between 6 and 12 weeks gestation of pregnancy. So those eggs have to last a fertile lifetime, and over time they become metabolically compromised and they lose the ability to make a baby. So while for a younger woman it's the average egg that can make a baby, for women over 35 it increasingly becomes the exceptional egg that can make a baby. And this is a graph kind of demonstrating that. We tend to ovulate about 400 times in a fertile lifetime. Women generally don't run out of eggs, but we do run out of time. And about 10 years before we go through the menopause, which is really when we run out of eggs, so not really when most people are trying to have a baby, at that point in time, really we've for a decade lost our fertility. So we run out of time before we run out of eggs. This is a little bit of a graphic description of that, but these are slides looking at the ovary of a young baby versus the ovary of a woman who's perimenopausal, and an in-between picture of a 25-year-old. Just to show that our eggs really do decrease in number over time. And however, it's really quality rather than quantity that affects reproductive health. You can see two embryos developing here in this video. These embryos, if you look in the bottom corner, are actually on a time scale that's quite different. So the camera is sped up on the embryo here at a faster rate. That's just the time lapse is running at a faster rate. But this is an embryo from an older egg. And you can see that the cell divisions are quite asymmetrical. The embryo doesn't look nice. It's got a lot of fragmentation. And it arrests its development before becoming a blastocyst. On the other screen, there's a lovely little embryo from a younger egg, and you can see that the cells are dividing in quite a nice and even way. They're approximately the same size when they divide. They're dividing at approximately the same time, and this embryo will go on to make a blastocyst that would be suitable for transfer. The embryo that is in this other slide that stopped moving, it's arrested at the stage that we call a morula. A morula is Latin for blackberry, and it's because an embryo at that stage was thought to look a little bit like a blackberry. A blastocyst is the stage that we like to transfer an embryo for IVF. It's usually achieved on day 5 or 6 of development. And now this embryo that's going to be blastocyst is at the morula stage, and you'll see that it then undergoes a process of compaction and then expansion. And it's now expanding into a blastocyst. It will develop an inner cell mass that's destined to be the baby, and an outer trophectoderm that's destined to be the placenta. And that's the kind of embryo that when you transfer, you have a very good hope will become a baby. So you can see that while the eggs are present and able to be collected through IVF from older women, embryo quality is drastically compromised, and the majority of eggs can no longer make a baby. That's one of the reasons why it does become harder to fall pregnant as you do get older. It's not the only reason. Sperm certainly is 50% of the equation, and sperm quality does also decrease with advancing paternal age. We also collect pathology as we age, so we're more likely to have significant burdens of other gynecological conditions like adenomyosis or endometriosis or fibroids, other concerns that can also cause problems in getting pregnant. So often when we do see women and couples who are struggling to conceive, the problem can be multifactorial, but certainly age and advancing age as a facet of infertility is a problem that affects everybody, no matter how fertile a woman was at her fertile peak. Certainly as she advances in age, it is absolutely predictable that fertility will decline. So what can we do? Well, look, I think one of the most important things to do is to be proactive, to see the whole chessboard in life, to, if at all possible, kick having babies up the bucket list, and also to look after ourselves. Certainly we can improve our chances of having better fertility by having a normal body mass index, by not exposing ourselves to harmful substances and toxins. But at the end of the day, no matter how healthy a woman is, age trumps lifestyle in terms of fertility. And a lot of my patients come to me and they say things like, before I've seen you, I've had 6 months of Chinese medicine, or I've had, kind of this, that, and the other supplements and complementary therapies, and I still can't get pregnant. Look, one of the things I say is that if something's not harmful, it's certainly not something that I would go at loggerheads against. But these kind of therapies really don't have the evidence base behind them to assist us to conceive. And certainly if you are over 35 and trying to have a baby, certainly seeking professional help and assistance if fertility is not happening, if conception is not happening, is really recommended because as infertility becomes prolonged in time, it does become harder for technologies to assist, because technologies like assisted reproductive treatments, IVF and egg freezing as a reactive treatment in the context of advancing maternal age are a lot less effective than as a proactive treatment. And we did discuss medical conditions like endometriosis and other gynecological problems. There are some women who are Medicare eligible for egg freezing. It's a limited interpretation and indication for medical egg freezing. Really, if a woman has endometriosis that is really significantly impacting her chance of having a baby, egg freezing definitely is something that would be part of the spectrum of her holistic care for endometriosis, and certainly that would be a Medicare eligible indication. Likewise, if a woman has a cancer diagnosis and is, as part of her treatment, undergoing what we call cytotoxic therapies like chemotherapy that can damage the ovarian reserve, or she's undertaking radiation therapy to the pelvis that might damage her ovaries, certainly egg freezing would be considered Medicare eligible and medically indicated. And just a plug for Melbourne IVF Fertility Preservation Service. We have a wonderful service at Melbourne IVF. If anybody has a friend, relative or acquaintance who has a tragic cancer diagnosis and would like to be seen for fertility preservation advice by one of our specialists, we have a roster that all year round, even over the Christmas New Year break, one of the Melbourne IVF fertility specialists is available for emergency and immediate appointments, so that in a timely fashion women with a cancer diagnosis can access fertility preservation in an urgent setting. And we also have our fellows at the Women's Hospital who we mentor, who are involved in that process. And we do in our clinic have many miracle babies born over the years from egg freezing, many of which have been born after a woman's undertaken egg freezing or fertility preservation in the context of a cancer diagnosis. So we're very proud of that. It's one of the reasons that Melbourne IVF has the best track record of any IVF unit that I'm aware of at helping women have babies from frozen eggs. We've been doing it for a long time, even before the technology was considered non-experimental. So certainly we have runs on the board in making babies from frozen eggs, and I can tell you that personally in my practice this year to date, I have 3 babies that I've helped to make from frozen eggs, and numbers are growing. It's early in the year. So who wants to freeze eggs and who should? Well, look, I think egg freezing is at its best as a proactive strategy, accessible to young women, certainly under 35 and ideally under 30, or close to 30, who have a good ovarian reserve, have eggs of robust metabolic potential, and can put away a good number in one attempt. I think that is the best and the most worthwhile time frame in terms of translating to the most number of babies that will be born per egg frozen. But I also think it's a very reasonable thing for women who are a little bit later in their reproductive life, closer to 35, to really consider, the difference being that you need to freeze more eggs because fewer eggs will be able to be as high quality, and in terms of translating to a live birth, the older you are when you freeze eggs, the more eggs you statistically need to make a baby. Some women come to see me, as I had a patient today who was 41 and wanting to freeze eggs. And look, I really have to have a very transparent conversation with women in that context, because older eggs don't do as well. They're affected by a high burden of chromosomal abnormality to begin with, and it is the exceptional egg over 40, not the average egg, that can make a baby. You do have to counsel women if they're delaying pregnancy beyond the age at which most people can have babies naturally, that they might potentially miss out, and that egg freezing at that age is not such a strong solution, because more eggs are lost to the process, less survive what is essentially a metabolic, quite a trialing process for the egg, and older eggs just don't survive as well, and they have less intrinsic potential to begin with. So a take-home message for egg freezing is, if you want to use it at its most appropriate, I suppose, in terms of achieving the goal of having babies from these frozen eggs, time point is to freeze eggs as a proactive strategy. The younger you are when you freeze eggs, the better the outcome, and the lower number of eggs are required to have a very good clinical chance of making a baby. I usually advise my younger patients to freeze approximately 20 eggs if they're under 35, and if they're over 35, depending on how far over 35 they are, I usually recommend freezing at least 30 to 40 eggs. And I find that that is really playing to win and allowing women to have enough eggs to have a really good chance of having one or more children. So the history of freezing eggs and why it's quite new is that in traditional freezing methods of slow freeze, we lost a lot of eggs to the process, and that's because ice crystals formed within what is essentially the largest cell in the human body, which has a lot of water content. We then developed vitrification, which is a process of egg freezing that avoids ice crystal formation by taking the eggs and taking the fluid content gently out of them by a process of bathing the eggs in various solutions that extract the water content, and then freezing them like a flash freeze method. So it's very quick for freezing and very quick for warming, and less susceptible to ice crystal formation and damage to the ultrastructure of the egg. The process of egg freezing is much like the first half of an IVF cycle. We see patients in our individual clinics as Melbourne IVF specialists and individually planned treatment. I personally believe that the best outcomes from egg freezing are with individualisation of care and making sure that you use the right treatment for the right person to optimise the outcome of the cycle and how many eggs are collected for that person compared to what they're capable of producing, but also to make sure that the patient experience is as side effect free as possible. The process involves using follicle stimulating hormone injections for approximately 10 to 12 days. And we also introduce other medications into the cycle to prevent premature ovulation, because we don't want our patients to ovulate before we can go and collect the eggs. We monitor by ultrasound to assess when the best time is to go and collect eggs for a given person and individualise that planning process. And then at Melbourne IVF, our model of care is that your treating specialist will do the egg collection personally, and all the fertility specialists at Melbourne IVF are very highly trained and highly qualified. Many, like myself, have a CREI subspecialist qualification, but all have great clinical skill and acumen in terms of performing egg collections. So certainly there is operator factor in how many eggs are collected, and ensuring that every follicle that can give us an egg has the best chance of doing so. And that's one of the ways that we pride ourselves on getting the best results for our patients who freeze eggs, and for IVF for that matter. The process takes altogether about 2 weeks, and in terms of appointments during that process, patients will generally have to attend 2 ultrasound appointments in the early morning during the process, and it will definitely be required that a day off work is needed for the egg collection procedure itself. Many patients will be comfortable to go back to work the next day, so it doesn't have to be something that's really invasive or intrusive on your working life. It's something that women can do while they do continue to work. We touched on the fact that you need to freeze a good number of eggs to have a good chance. and it's about quality as well as quantity. The younger you are, the fewer eggs will translate to a baby. The older you are, the more eggs would be recommended to have as your backup strategy, which is essentially what egg freezing is. So what should be expected, and I say this to my patients who are having IVF as well, it's really important to understand when we think about how many eggs we freeze, the attrition process in IVF and in human biology. So one way that I explain it is that if you have two individuals, heterosexual couple who are trying naturally to conceive, let's just say they're 22 years of age and very fertile, I would say they have a 1 in 5 chance of getting pregnant every month. So that's our baseline. That's 1 egg released per month. So what that tells you is 1 in 5 eggs can make a baby, best case scenario for the human. When you do get older, it's harder than that. So what we say is that, about 10 eggs collected that are frozen will translate to about 8 or 9 surviving the process. We lose 10% of eggs for women under 35, 20% of eggs for women over 35, and that's because it's the process's effect on the metabolically more compromised egg. It's not as well tolerated. And from that, we would expect 3 to 4 embryos, of which 1 to 2 will make it to be a blastocyst. And a blastocyst has about a 40% chance in our lab of making a baby. So you can see that you've got to buffer that egg number so that at the end of the day, you have a very reasonable chance of achieving a live birth. This slide is advertising the cost of egg freezing at Melbourne IVF. At Melbourne IVF, the difference that we are proud of compared to many other providers in the field is we are incredibly transparent about our cost structure. There's no sneaky asterisks in our cost structure. Everything is included. We quote not just for the laboratory and surgeon aspects of treatment, but also for the medications, for the hospital admission, for the anaesthetic doctors, services to help you go to sleep, for your egg collection, for the hospital bed fee, for the storage fees for the first year of keeping eggs frozen. Medication is generally about $1,500 for an egg-free cycle. Obviously, with individualisation of care, you may need a little bit more, a little bit less than average, but that's a ballpark figure. That's a realistic expectation. And Melbourne IVF also have very generous payment plan options where the out-of-pocket upfront cost is $1,500 with the balance to be paid over 12 months, which is an option that many of my patients are very happy to take up. Some other points to consider is that the only guarantee that you can definitely have a baby is to have a baby. I think egg freezing belongs in the kind of grander scheme as trying to optimise your overall chance of conception by covering all bases, but certainly it's not a replacement for having a baby. And I would encourage women to really consider if they are, especially over 38, whether having a baby now might be a better option for them. If not in a relationship, we can assist many women to conceive using sperm from a donor. And it's an option that I do help single women with on a daily basis. It's not everybody's choice to do that. For some people, it's a deal breaker. But even with frozen eggs, you can return and use your frozen eggs with a partner or with a donor. So if you would like to have a baby and you need help to think about how that might happen, certainly we'd love to hear from you and love to support you if that's going to make your dream come true of parenthood. And we have in our donor program recruitment of sperm donors from Australia and also from international sources, as long as they comply with the Australian requirements for donors, which is that the donation is given freely and altruistically, and also that the donor's details are registered on the donor register, so that when the child comes of age and is 18, if they want to know more information about their donor, it's not a brick wall. They have some recourse to find out some information. So that's the end of the presentation. I'm just going to stop the screen share and go back and see if we have any questions for me to answer. Okay, so feel free to go for the questions. I have this question from Elle. If you're 30 and single, would you recommend freezing eggs and embryos by donor in case you never meet someone and decide to have a baby on your own, as this will help reduce the number of eggs lost due to unfreezing? Look, I think that's a complicated question. I don't recommend using donor sperm to freeze embryos, and in fact it's actually quite difficult to do that because we don't want to, as an IVF unit, use up our donor sperm to freeze embryos that are unlikely potentially to be used in the future. A woman's much more likely to use her eggs with a partner than with a donor. And when we do have sperm donors, we have a limited number of donations that can be allocated to form families every year. So in Victoria, for example, one sperm donor can only contribute sperm to a maximum of 10 families, including their own. In some states, it's 5 families. So you can understand that we may really compromise the variety and availability of donor sperm if we froze a lot of embryos. There are also moral and ethical considerations in terms of creating an excess number of embryos, whereas eggs are a lot less loaded, I suppose. They belong to just you. They by themselves can't create a potential baby without the sperm. They are less emotionally challenging to consider discarding or donating to someone else if you don't need to use them yourself. So yeah, I wouldn't encourage that. Certainly embryos do better with freezing than eggs do. They're just very different entities. So we saw that not every egg makes it to be an embryo, but an egg is a single cell, and while we really have made amazing leaps and bounds in egg freezing, embryos are, by the stage of being a blastocyst, they're pluripotent little balls of stem cells, and if you have a blastocyst that has about 150 odd cells and a few cells are damaged by the freezing and the warming process, that embryo can rally and it can recover and it can still make a baby. So it's just a very different entity to an egg. But, if you are 30 and freezing eggs, I would expect that you'd be able to get a really good number, and I would expect that the eggs would be of high quality and of high metabolic potential, and that most likely, if you have a specialist who guides you to freeze a good number, the chance of having a baby from eggs at that age is actually excellent. Next question, would you recommend having IVF straight up or egg freezing over the age of 35? Look, I think it's so individual, isn't it? I would certainly say that, like I said, it's kind of my catchphrase, but the only guarantee that you can have a baby is to have a baby. And if you're ready to have a baby, I'd encourage you, if that's what you would like to do, that we can support you to do that. And in this day and age, it's no longer such a stigma or taboo for women to decide to become mothers in conventional pathways. So I certainly think that it's very reasonable, if you're ready to have a baby, to help a woman to conceive. And she may not need IVF. She may be able to have donor insemination and conceive. So it's a little bit individual. I think everything has to be individualised for that person. Some women who freeze eggs over 35, to them it's an absolute deal breaker to have a baby by themselves, and I respect that as well. For some women, that's just the way that they feel. They feel that they want to have a family. It's actually really important to them to have a genetic connection to a child if possible by having their own egg, but that they just can't come to terms with the idea of having a baby by themselves without a partner. And I would say that is probably the most common scenario for women considering egg freezing over 35. but it is a reactive strategy rather than a proactive strategy, especially when a woman of 37, 38, 39 comes to talk about egg freezing. They're already past the point where their fertility has begun to biologically decline. So it's no longer a proactive planning strategy, it's a reactive strategy to the fact that they're getting older. And as a strategy, it's less effective in that context. Does being on the pill beforehand have any impact? So just the way the question's worded is a little bit, could go two ways. So I'm going to answer it in two ways. So certainly sometimes women worry that being on the pill for many years can impact their fertility adversely, which is absolutely not the case. It's an urban myth. But what the pill does do is it masks what's going on beneath the surface. So women might think that they've got a regular clockwork menstrual cycle on the pill, and actually they stop taking the pill, and either the unearthed problems that might have been there to begin with, which were part of the reason why the pill might have been prescribed in the first place, or things have evolved as they've gotten older that have been kind of under the radar because they've been on the pill. Certainly being on the pill does not halt ovarian reserve decline. Ovarian reserve decline happens continuously, whether you're on the pill, whether you're not on the pill, whether you're pregnant, all the time, from when we're born until when we go through menopause. So it certainly doesn't have any impact on your fertility by making your fertility worse or impairing your fertility, but nor is it protective. Now, the question may also be, does being on the pill before you do an egg freezing cycle adversely impact your chances? Well, I personally think it does a little bit, and I prefer women not to schedule cycles off the pill if at all possible, for two reasons. One is that statistically speaking, we know from scientific studies that you will get a couple fewer eggs if you go for a cycle straight off the pill. But more importantly, one of the regimens I like to use for egg freezing to make it as absolutely safe as possible, which is more relevant for women who have a really reasonable or good ovarian reserve, is what's called a GnRH antagonist regimen with an agonist trigger. And that's one of the regimens that is suited for women with ovaries that are capable of a complication of egg freezing called hyperstimulation. And it really minimises the risk of hyperstimulation so that I can really go for really great egg numbers and keep my patient entirely safe. Now, going off the back of the pill, she may not react so well to that regimen because her pituitary might be a little bit sleepy from being on the pill. So my concern with being on the pill is more a safety concern in that context for women who have a high ovarian reserve, because if you have a high ovarian reserve, the fact that you'll get one or two fewer eggs in the cycle is less important. So that's my stance on the pill and egg freezing. I like to take women off the pill about a month before we go through a cycle of egg freezing. The exception to the rule is someone with a low ovarian reserve who has endometriosis. And if we're talking about egg freezing in that context, the pill's virtue is that it is keeping that endometriosis asleep and not activated. And so in that context, it is an exception to the rule, and I generally would schedule a cycle off the pill. Now we have a question. Are there increased risks of ovarian overstimulation if I only have one remaining ovary with IVF drugs due to past ovarian cancer? I'm sorry to the person who's had a previous ovarian cancer, but I'm very happy to see that you've survived the process and are well now. No, you definitely don't have an increased risk of ovarian hyperstimulation, but obviously it's something to consider that if you do only have one ovary, you've got to weigh up the pros and cons of the various benefits of egg freezing versus the risks, because in 1 in 1,500 cases, there'll be some kind of complication. It's generally minor, but can be serious. I've never had a patient lose an ovary from either IVF or egg freezing in my practice in all the years I've been practicing and all the hundreds and probably thousands of OPUs that I've done to date, of pick-up procedures. But it's a possible complication. So I just say that you should probably need to have really personalised and realistic counselling about those risks, given that it is your only ovary. Is egg freezing a good idea if you have PCOS? Well, look, it's not a good idea or a bad idea. It's about context, egg freezing. You know, the question is not do you have PCOS, but are you going to delay having babies? In terms of PCOS, if somebody does want to freeze their eggs, PCOS is an absolute gift to egg freezing. it is a time where it really is an advantage. You can, with big, powerful polycystic ovaries, collect an amazing number of eggs in one go, and it's generally a very good strategy in terms of your chance of having babies in the future if you do it at a reasonable age where the eggs are of quality. It is possible with polycystic ovaries to have, with PCOS, to have a lot of eggs that are of poor quality. So women who are older still do struggle with PCOS in terms of egg quality, but certainly egg number is not something that is a concern. And I would say egg freezing for women with PCOS is potentially more cost effective than for someone who has a more normal ovarian reserve. Is there any way to improve egg quality or any way to test the quality? Well, you test the quality by having a baby. We really see a lot about egg quality in the IVF lab. And even with couples who suffer infertility, sometimes I always say a first IVF cycle is very diagnostic as well as potentially therapeutic. I'll give you an example. I have a couple in my practice, obviously without disclosing identifying information, who recently took through an IVF cycle, and unfortunately they have not been successful in this round of treatment, but we did learn really why things weren't happening in nature. While at a reasonably young age, with a history of 6 years of primary infertility together, when we did do the IVF treatment and had the privilege of looking at the eggs and the sperm in the lab together, the egg quality was dire. And really I was shocked to see eggs behaving like eggs would of a woman 10 years her senior. So we sometimes do really learn a lot about egg quality in the IVF context. But in terms of age-related fertility, I would say that the most useful information is how old you are and what your cohort of women of similar age experience in an IVF context, because then we can look at outcomes for hundreds of thousands of women from around Australia and internationally, and see what eggs and sperm do at different ages. And certainly we know that egg quality declines with time. There are some women where it happens more rapidly and some where it happens more slowly. Like any average, there are parameters that fall outside the mean of the bell curve. But no, there is no test. An egg is a single cell. If you take its nucleus to check its DNA, you destroy it. The way to test an egg quality is to add sperm and make a baby. So it's one of those things that we gauge on the basis of age. All right, well, thank you for participating. Is there any further questions? And I have one more. Here we go. I'll just ask you to ask your final questions, so everybody get in their questions, and I'll answer a few final questions and then we'll sign off. So the question is, being single and being on the oral contraceptive pill to reduce symptoms of endometriosis, potentially, but not formally diagnosed, is there no operation to look and see if there is, given 35 bracket, given the patient or the woman is in the 35-year-old bracket? What would I suggest with egg freezing, etc.? Look, I think it's really a question. Maybe the question underneath the question is, are you Medicare eligible for egg freezing? And being on the pill to manage period pain symptoms doesn't, unfortunately, make a convincing diagnosis that really would render a patient Medicare eligible for egg freezing. Certainly, if you have symptoms of endometriosis that warrant further explanations, I would encourage you to see a specialist. It could be a fertility specialist or a laparoscopic gynecologist. We often are both. So, you could be offered the opportunity to have a laparoscopy and have a look inside your tummy, which is the gold standard for diagnosis of endometriosis in the absence of ultrasound signs. We do have really excellent ultrasounds these days that can often pick up very soft signs of endometriosis, and often to do a deep endo scan. The scan's performed by a gynecologist with a subspecialist interest in ultrasound, and you do a bowel prep so that the bowel is empty and you can really push the probe to see if there's any lesions between the bowel and the back of the uterus. So that's often something that can do to diagnose endometriosis sometimes. But the difficulty with endo is it's not necessarily a 3D condition. Often lesions are more two-dimensional, and ultrasound is not perfect. And the gold standard for diagnosis is still considered laparoscopy. We don't have any really good biomarkers that can definitively diagnose endometriosis on a blood test. In terms of egg freezing, I'd really think more about where you're at when you are likely to consider having a baby, and if that is not on the agenda and you're 32, I think egg freezing is a really smart thing to do, to give yourself that kind of backup strategy, that plan B. Your eggs are at the best that they will ever be from this time point moving forward, and it gives you the best possible plan B that you can have. So further question, with ART, is ICSI a safe technique over normal IVF as the egg will suffer trauma from injecting the sperm? Great question. So ICSI is a technique that has been developed to overcome male factor infertility. Currently for egg freezing it's used in general. That's because the process of egg freezing does result in a hardening of the zona pellucida, and there's some concern that normal insemination of sperm, as is performed in standard insemination IVF, may have a higher risk of failed fertilisation. So we do use ICSI for our frozen eggs. In terms of eggs more likely to be damaged by the needle than by standard insemination, well, yes, they are a little bit, but it's not a profound effect. And also, in terms of standard insemination, there are cases, even in IVF, where, and in 50% of cases, there's a male factor, and that's why couples are coming to IVF in the first place. And so standard insemination may not be used because we're worried about failure of fertilisation as part of the underlying pathology that's brought couples to seek help. So certainly ICSI is something that should be reserved for male factor infertility or other clear indications, and it shouldn't be used for all patients, especially in the absence of a male factor. But certainly, it is an amazing technique that has helped millions of men who would never have been fathers around the world to have genetically related children. So it's certainly not a terrible thing either. Do you need a doctor's referral to attend Melbourne IVF? So all the fertility specialists of Melbourne IVF, we're a group, we're a family at Melbourne IVF of collegiate doctors, but we are also independent practitioners with our own medical practices. So the way to meet and to have the advice of a Melbourne IVF fertility specialist is to get a GP referral and make an appointment. And you can find the contact details for all our Melbourne IVF specialists on our Melbourne IVF website. And we're located in various places across Melbourne. So I'm sure no matter where you live, there's a specialist who is close to you and who might be able to assist if you need help. All right, well, I might wrap up there. Thanks for attending. Don't forget to check out my podcast at Knocked Up. If you need our contact details, have a look at the Melbourne IVF website. It's a pleasure to speak to you tonight, and best of luck for the future. Take care.